Hi, my name is Victoria Parikh. I'm a cardiologist and genetic specialist at the Stanford Center for Inherited Cardiovascular Disease. It's really a pleasure to be here today to talk with you about what we know and what we have left to discover about treating Desmin cardiomyopathy. So Desmin cardiomyopathy was first described actually in the year 2000, so more than 2 decades ago, where we noticed that families presented with really terrible arrhythmias and also with weakened hearts, both on the right ventricle, the right side of the heart, and the left side of the heart. At that time, it was also noted that when you had these Desmin cardiomyopathies, that you might also have skeletal muscle anomalies, meaning that you could have weakness in your skeletal muscle and have really an early onset of just an inability to do the things that you wanted to do in your daily life, because it wasn't just your heart that was affected, it was really the rest of the muscles in your body. And after some time and collecting a small cohort of patients that had this type of disease, scientists and doctors were able to discover that what was happening was that there were variants or misspelling in the Desmin gene, and that Desmin gene, when it has a variant in it, actually misfolds or doesn't become the right shape. And it turns out that we need Desmin to be this sort of long rod so that we can build multiple rods together to build a scaffold for inside of the cells that make up the heart. And so when we had these variants, these disease-causing variants or misspellings in the genetic code, those long rods either didn't fold into long rods or didn't assemble into the scaffolding that needed to happen to keep the cell healthy. So this led not only to there not being a strong cell scaffold, but also to this formation of these aggregates or conglomerates of proteins that hadn't folded correctly or assembled correctly. And those conglomerates, which we call aggregates, we know actually also cause the heart to be sick. They cause these cells to die. They cause abnormal beating of those heart cells, which can lead to arrhythmias. So we know then now that Desmin can cause disease in 2 ways. The way that I just described to you with single variants is listed at the bottom, those gain of function protein aggregate forming variants. At the top, I have listed loss of function variants. That means that you're just not making enough protein at all. Now, in that type of disease, you need to lose both copies of the gene in order to get disease. But that does lead to this very early onset pediatric or childhood presentation of a lot of skeletal muscle weakness and rapid onset heart dysfunction or cardiomyopathy. We are going to focus on the second type, the gain of function protein aggregate form today, because that really does have onset in adults between the ages of about 20 and 50. And we'll talk in more detail about what that looks like as we go forward. I did want to point out on this slide that there is a really distinct difference in the way that the protein acts in terms of its architecture or that cellular scaffold in the cell when it's normal, or what we call wild type in the scientific world. Over here on the right is a picture of what normal Desmin looks like. You can see sort of this cobwebby appearance in yellow. That's the Desmin doing the job it's supposed to do, making that scaffolding for the cell. But over here on the left, what you see is little tiny bubbles that hold Desmin together, and you don't get that nice scaffolding. You actually just get a bunch of these tiny protein aggregates, which it turns out are really driving the cause of the cardiomyopathy here. Now, in terms of how common Desmin cardiomyopathy is, it's actually a pretty rare cause, as far as we know, of dilated, restrictive, and arrhythmogenic cardiomyopathies. It does, however, definitely cause these cardiomyopathies. What you can see here is a sort of gene list from a really important publication that came out in 2017 from Roddy Walsh's group. And what it shows is that if you have a dot and line farther to the right associated with your gene, then you're more likely to actually be responsible for disease. So Desmin is right in here under dilated cardiomyopathy. And what you can see is that it is definitely shifted to the right, but it has sort of long overlapping error bars around it. So what that means is that it's not clearly associated with the dilated cardiomyopathy context, though we do tend to see more variance in it there. But down here in arrhythmogenic cardiomyopathies, here specifically of the right ventricle, we see a very tight line around that dot. And what that means is that we're very confident in that case that Desmin variant was responsible for the cardiomyopathy. So what this brings us to is that we have small numbers of patients who we have definitely diagnosed with the Desmin cardiomyopathy. 1 to 2% of folks with an inherited cardiomyopathy that's dilated will have a Desmin variant that we know to be pathogenic. But that in general, these are very arrhythmogenic variants, meaning that they may not present with heart failure and then be classified as dilated cardiomyopathy. There could be many of these patients sitting in a population that presented with sudden cardiac arrest or other life-threatening arrhythmias that may have a causative Desmin variant that we just haven't been able to characterize yet. So that brings us then to the discussion of are we underdiagnosing Desmin patients? And this is where genetic testing, of course, is really important, but we're making the data that comes from those genetic tests from each patient, we're asking those patients if they're willing to share the data about their variants of uncertain significance, meaning misspellings that are identified on their genetic test, but those misspellings actually, we don't know whether they cause disease or not. This is where those variants of uncertain significance come into play. So we can actually test some of those variants of uncertain significance in the laboratory. You can see some really beautiful data here from our colleague, Andreas Brodell, where he basically puts individual variants, each one of these sort of pie chart circles is a different variant, into individual cells. And then he looked to see, did we get those aggregates forming, those tiny punctate dots, or did we get a normal distribution of that cobwebby looking cytoskeletal structure, that scaffold? And so the variants that have sort of a red circle are the ones where we actually saw those variants causing the aggregates. And so we can be pretty confident that those then cause disease. But there are about 8,000 potential variants in Desmin. And so to go through each one of those individually is very difficult. We are currently working on some high throughput methods to be able to characterize each one of those misspellings, 8,000 variants, as being aggregate forming or not. And we hope that this will help us to identify those patients with Desmin variants of uncertain significance who actually do have Desmin cardiomyopathy going forward. So then what do we know about the clinical manifestations of Desmin cardiomyopathy? I'm going to tell you about work from two major groups, one at Johns Hopkins and a group of European folks in London and Spain, who, as well as Italy, who came together to try to better understand what the clinical course of Desmin cardiomyopathy is. The first question they tried to answer, and this is from the Hopkins group, is what type of cardiomyopathy do Desmin variants cause? So it turns out that these different colored dots here represent different types of cardiomyopathy that were reported with these different Desmin misspellings or variants in the literature. And what you can see is that there's really not a good pattern of who got a hypertrophic cardiomyopathy versus arrhythmogenic right ventricular cardiomyopathy or ARVC versus just a plain old dilated cardiomyopathy. And what that tells us is that our imaging is not a great way to classify Desmin variants and to understand whether or not they are going to cause a really feared outcome like sudden cardiac arrest. That Spanish and British and Italian group that I mentioned to you did do some really great work in characterizing what the ECG looks like for Desmin patients. A lot of what they showed was that there were what we call T-wave inversions, meaning that the part of the cardiac cycle where the heart is repolarizing or resetting itself for the next beat actually has abnormal electrical flow. They also saw that the voltage, meaning the size of the electrical signal in the hearts of patients with Desmin, was reduced. They saw a lot of arrhythmias that weren't life-threatening but were early signs of arrhythmia called non-sustained ventricular tachycardia and PVCs or premature ventricular contractions. They saw a really mild imaging evidence, which fits with what we were just talking about, right? Most of these patients had a fairly normal size of their left ventricle, maybe slightly dilated, and just a little bit of reduction in their systolic function or squeezing function, meaning that this is a cardiomyopathy that could be missed if we were using echocardiography or even MRI alone. They did show that about 50% of patients with the cardiomyopathy had specific MRI findings like ring-like late gadolinium enhancement, which is like a scar that goes all the way around the left ventricle. And then they showed that a really high percentage of these patients were having bad outcomes. So 12% ended up with advanced heart failure, meaning that they needed to be considered for an LVAD or for transplant, and 20%, which is a really large number, had a major arrhythmic event, meaning a sudden cardiac arrest or having an ICD or defibrillator shock. So it's a pretty significant cardiomyopathy that's characterized by a lot of arrhythmias, and a significant amount of these patients will progress to needing transplant or to needing an LVAD, even without arrhythmias themselves. So zooming out a little bit and trying to ask at a population scale what the sort of rate of bad outcomes is for these patients. This data is from the Hopkins group. And what they showed is that in general, events or bad things like arrhythmias and heart failure start to occur for these patients in their 20s to 40s, much earlier than folks who are out in the world without a Desmin cardiomyopathy, who have, for example, heart attacks, et cetera. They showed actually that there's something called conduction system disease in these patients, meaning that they might need a pacemaker to keep their heart pumping because the atria, the top of the heart, and the ventricles, the main squeezing part of the heart, don't communicate very well. And that's likely due to cell death from those aggregates we were talking about. Again, about 25% between the ages of 20 and 60 developed a sustained ventricular arrhythmia. That's a life-threatening arrhythmia. And about 30% ended up with a heart failure event, like a hospitalization or needing to have a transplant. So the take-home point here is that this is an arrhythmic cardiomyopathy, that it comes with actually a lot of conduction system disease like heart block, and that the heart failure risk is high, and that this is probably really irregardless of the imaging phenotype, meaning that when we screen patients for this disease, we need to really be open to looking specifically for early arrhythmias and conduction system disease rather than only getting an echocardiogram. Some additional work from the European group that I was telling you about really tells us what a Desmin variant means for someone who has a family history of cardiomyopathy, but has not themselves yet been diagnosed with cardiomyopathy. In that cohort of patients, of the 68 individuals who had a phenotype, not a phenotype, meaning heart failure, but who had information about what their heart looked like at the time of their first evaluation, 36 of those, which is about half, didn't have any symptoms. And 52 out of 68 of the patients that they followed actually were detected through family screening. And so what that means then is that they're carrying a variant, but they're very likely to be asymptomatic, but they may actually have a sign on their screening, like their ECG or their rhythm patch monitor or their echo, that says, hey, you need to be protected from sudden cardiac arrest. This paper went on to look at what the risk factors in Desmin cardiomyopathy were for sudden cardiac arrest, and they identified male sex, the presence of non-sustained VT, and a left ventricular ejection fraction that was just less than normal, at less than 50%, where normal is 55 to 65%. They didn't have enough events in this particular cohort to isolate this to sudden cardiac death. These were risk factors for heart failure and for other major ventricular arrhythmias as well. But coming along the theme of how your heart looks in this disease is not as indicative of your risk as it is in other types of cardiomyopathy. So we and others are thinking about therapy for Desmin cardiomyopathy. We are trying to figure out where along the spectrum of having a genetic variant all the way through making those aggregates and causing disease of those heart cells we might intervene. Certainly novel therapies that are targeted by CRISPR gene editing, which you may have read about, which won a Nobel Prize, are really exciting long-term potential. But getting CRISPR-Cas9 to the heart in a way that meaningfully will help to edit without causing other problems, the specific misspelling that's causing the issue is difficult. Additionally, by the time we find cardiomyopathy in those patients, changing the gene may not be enough. We may have to be able to resolve the protein aggregates that have already formed and poisoned those cells. So there are some small molecules that have been developed to try to prevent the formation of those aggregates and to try to break up those aggregates themselves that folks have published on previously, but which have not yet made it to the preclinical setting and hopefully will very soon. So in summary, Desmin cardiomyopathy presents in adults, and it's caused by an aggregation of the Desmin protein due to its misfolding and disrupted assembly of its normal cytoskeleton or scaffold in the heart cell. It causes about 1 to 2% of inherited cardiomyopathy, but we may be missing some of those because we haven't yet characterized every variant of significance or pathogenic variant in the Desmin gene itself. It is highly arrhythmogenic, independent of the way that the heart looks on an echo, and that may be related in particular to male sex, to what we see on rhythm monitoring with non-sustained BT, and to the ECG itself. It is likely very penetrant, meaning that if you inherit a misspelling in Desmin that causes disease, you yourself are very likely to develop disease at some point in your life. And that is something that's very difficult to quantify given current data, but we do think that male sex does increase that penetrance at present. And then lastly, there are multiple potential ways to treat Desmin. There are folks working on this. And I think that coming up with precision therapies, especially for a cardiomyopathy like this, is going to be really important to protecting the people that we can identify who are at risk. With that, thank you so much. It's been lovely to speak with you today. I hope you have a wonderful rest of your day. And we at Stanford Center for Inherited Cardiovascular Disease, as well as many of the genetic cardiomyopathy centers around the world, are more than happy to see you, your friends, or relatives with Desmin cardiomyopathy. Thank you so much.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.